come up with efficient ways to conduct therapy for. This group of people are patients with post-stroke aphasia. There has been much debate over the amount of intensity speech pathologists should give to their aphasia patients. I am hoping to help us answer this question during the remainder of my presentation. My interest in this topic came from the lack of evidence-based practice the field of speech-language pathology has on the most efficient treatment for patients with chronic post-stroke aphasia. It is our job to give our patients the most optimal care possible to better their quality of life, even after they discontinue therapy, especially after they discontinue therapy. According to the National Aphasia Association, aphasia can be defined as an impairment of language, affecting the production of comprehension of speech and the ability to read or write. Aphasia is always due to injury to the brain, most commonly from stroke, particularly in older individuals. Aphasia may affect mainly a single aspect of language use, such as the ability to retrieve the names of objects, or the ability to put words together into sentences, or the ability to read. More commonly, however, multiple aspects of communication are impaired, while some channels remain accessible for a limited exchange of information. As future SLPs, it will be our job as professionals to determine the severity of speech and language deficits post-stroke aphasia patients have and how it affects the availability of each individual's channel for their comprehension of language, and to assess the possibility that treatment might enhance the use of the channels that are available. My research process included databases such as Google Scholar, PubMed, and the ASHA website. Keywords and phrases I used to find my articles included post-stroke aphasia, speech-language therapy, intensity, prevention, constraint, and rehabilitation. The articles I used were qualitative studies, single-subject designs, and systematic reviews. The 5 articles I found looked at the efficacy of intensive aphasia therapy in patients with chronic stroke, the effects of the intensity of treatment and constraint-induced language therapy, and the effects of constraint-induced aphasia therapy on naming deficits, and the effects of dual transcranial direct current stimulation. I will first discuss a qualitative study on the efficacy of intensive aphasia therapy in patients with chronic stroke through a randomized control trial. This study helps further determine the optimal daily dosage and total duration of intensive speech-language therapy for chronic post-stroke patients. Aphasia patients. Participants were put into 2 groups. Group 1 received therapy for 2 hours daily, while Group 2 received therapy for 4 hours daily. The results suggested that no added value came from more than 2 hours of daily speech-language therapy. However, their results demonstrated that a 2-week increase in treatment duration contributes substantially to recovery. The next article is an evidence-based systematic review that looked at the effects of intensity of treatment and constraint-induced language therapy for individuals with stroke-induced aphasia. A systematic search of the aphasia literature identified 10 studies meeting inclusion and exclusion criteria. In chronic aphasia, the studies reviewed provided modest evidence for more intensive treatment and the positive effects of constraint-induced language therapy. Modeled after constraint-induced movement therapy, which focuses on therapy for limb weakness after stroke. This is based on the notion of learned non-use, the tendency to rely on the stronger limb, thereby hindering rehabilitation of the affected limb. The next article was a single-subject design that aims to investigate the efficacy of constraint-induced aphasia therapy, or CIAT, on naming deficits in individuals with chronic aphasia. Patients received CIAT for 4 consecutive weeks, 3 days a week. There was a positive trend in their naming score during the treatment phase compared with the trend in the baseline demonstrated by both participants. The results of this study showed that the constraint-induced aphasia therapy can be effective in improving the naming deficit in patients with chronic post-stroke aphasia. The next article is similar to the previous one, but is a systematic review of randomized controlled trials concerning the effect of constraint-induced aphasia therapy in post-stroke patients with aphasia, and to identify the useful components of constraint-induced aphasia therapy and post-stroke aphasia rehabilitation. CIAT may be useful for improving chronic post-stroke aphasia. However, there is limited evidence to support its superiority to other aphasia therapies. Mass practice is likely to be a useful component of CIAT, while the role of constraint is needed to be further explored. Research showed that CIAT embedded with social interaction may gain more benefits. The last article aimed to determine if there is an additional effect of dual transcranial direct stimulation, or TDCS, after comparing it to single TDCS in chronic stroke patients with aphasia. A cathodal electrode was put over the left buccinator muscle, and a single anodal TDCS was put over the left inferior frontal gyrus. You guys know the one. Anodal means to excite neural activity, while cathodal means to inhibit or reduce neural activity. During dual TDCS, the stimulator was put on both the left and right sides. Each stimulation was activated for 30 minutes at a time, and speech therapy was given to the subject for the last 15 minutes of stimulation. The Korean-Boston naming test and a verbal fluency test was given before and after stimulation. Both the single and dual stimulation proved to be very effective and showed an increase in improvement in the number of correct responses after they were stimulated. However, neither dual or single stimulation had much of an effect on the verbal fluency test.
And lastly, remember, you are not working on an island. You want to be a part of an interdisciplinary school-based experience.
I think that's your voice still. After reviewing each article, it is evident that a more intensive speech therapy approach for aphasia patients compared to a less intensive speech therapy approach does not have significant gain for chronic post-stroke aphasia patients. The research also proved that the best care for aphasia patients included a multimodal approach to therapy. Thanks for listening.